Hello, everybody. My name is Maria Maiaru, and I am a lecturer in pharmacology at the Reading School of Pharmacy. Today, I will briefly talk about pain and discuss with you whether we need more painkillers. Hopefully, towards the end of this video, it will be clear to you why do we need more painkiller. We are all very familiar with these type of picture. Nowadays, painkillers are available at the supermarket. We can buy them and we don't need a prescription from our GP. And because of the amount of painkillers drugs available, you can wonder why do we need more painkiller and why do we need more research in the field of pain? Well, one of the big challenge we are facing now is to develop safer and effective drugs. Yes, I said effective because unfortunately there are some types of pain, chronic pain, and we will see it later, for which we do not have an effective treatment yet. Moreover, the pain relief achieved using currently available drugs is only partial, and it is very often associated with serious side effects. A survey carried out a few years ago in 16 countries documented that chronic pain is a major healthcare problem in Europe. This study showed that in the population of chronic pain patients, 52% of them were taking medication at the time of the research. 21% say they never taken medication, and 26 stopped to take medication to treat their pain. And the main reason for this patient to stop taking the medication was because they thought it was no helping them, and also because of serious side effects. In fact, when the pain patient were asked whether their pain was under control using drugs, as you can see, the percentage of positive response was very low. In the UK, as an example, less than 40% of chronic pain patients say that their pain was effectively controlled. At the moment, the gold standard for pain are opioids. However, recent data have suggested that for chronic pain, while opioids have a good short-term efficacy for chronic pain, there is less evidence for long-term efficacy beyond 6 months. You may be aware of the opioid crisis in the United States, where over 2 million of people have opioid use disorders, with most starting with prescribed opioid painkiller. An opioid overdose is now the second leading cause of death in the USA. And unfortunately, we are observing the same problem in Europe and here in the UK. So after the full lecture and further reading, you will be able to define pain, to describe pain and the two component of pain, the sensory and the emotional component of pain. And you will learn that because of this emotional component, the treating pain it can be very hard. You will also understand the different types of pain and how we rate pain. You will be able to describe the nociceptive pathway and the mechanism of pain transduction. And we will also discuss the different classes and clinical uses of therapeutic agents together with new pharmacological agents that are currently under investigation for the treatment of pain. Now, in order to understand whether we need more painkiller, it is important to understand what is pain and whether we need pain. I particularly like this quote from this famous movie. This quote say, "Pain is your friend, is your ally. It will tell you when you are seriously injured. It will keep you awake and angry and remind you to finish the job and get home. But the best thing about pain is that it lets you know you are not dead yet." And I particularly like this sentence because this quote because describes very well the protective role of pain. So pain is an important alarm system. In order to survive, animals, human as well, must avoid injury and be able to detect potentially damaging stimuli via nociceptive mechanism. For example, when we touch something that is sharp, or as in this picture, when we get too close to the fireplace, the activation of nerve endings in our hand will alert our brain, and we will withdraw our hand to prevent further damage. And the important role of this alarm system is dramatically clear in individuals with congenital abnormalities, as they do not feel pain. Just a few years ago, it was discovered that there are some natural mutation, where people, in fact, most children, do not have a functional sodium channel. And in the full lecture, we will describe why this channel is important. People with this mutation, they have no pain at all. And this is no good because they get internal injury and never report pain, and they may die young. Here is an example of a little boy with congenital insensitivity to pain. And we say that pain is useful. Acute pain is useful. It's a warning signal. So under normal circumstances in everyday life, when we experience pain, we go away, we get out of the situation. But the little boy in this picture, he never feels pain. What they had to do, they had to remove his teeth because he can literally bite his nails and amputate his limbs. So how is pain generated? So this is a very early view, and Descartes that was not he didn't study pain, but he was interested in perception. So he did write about pain. He postulated that when you burn your foot, the information travels up to the leg, the spinal cord, and then goes to the brain. So the activation of specialized nerve endings in the periphery will send the message to the brain, and the brain will interpret it. There are some textbooks that use the definition of pain transmission or pain pathway, but this is wrong. There is not a pain pathway. There is a nociceptive pathway, and in the full lecture, you will learn how it works. Because, of course, the pathway is a bit more complicated than that. So we will learn a bit more about how does pain get generated in response to an injury, what happens as the information transit into the spinal cord and up to the brain. So in the full lecture, I will take you on this little trip. Briefly today, I will describe the nociceptive pathway. So in the body, we do have important specialized pain detector called nociceptor. These are nerve cells, so they can send conduct electric signal, sending information up to the brain. And it's only when the signal reaches the brain that we experience pain. The spinal cord plays an important role of this pathway because all the information coming from the periphery will be processed at spinal cord level and will be then sent up to the brain, and the spinal cord level will also receive information from the brain. It is important to distinguish pain from touch. For example, when we touch a needle, we feel it, but it's not painful. However, if we push it harder, it becomes painful, and these specialized nerve endings get activated and send a message up to the brain to stop us. This is because we have reached the threshold of activation of nociceptor. There are molecules, chemicals, that can reduce the threshold of activation of nociceptor, lowering the threshold for pain. So, for example, when we injure ourselves with a needle, the producing tissue damage starts a process called inflammation. And the damaged cells start to produce some chemicals that will lower the threshold of nociceptor to the point where also touch is painful. The best example, so if you think about when you had any tissue injury, even the area surrounding the wound was painful. And this is because the inflammation in that particular area, so the release of all these chemicals was lowering the threshold of nociceptor. So the lightest touch will be can be painful. And this is another example. So when we burn ourselves, it's not just the wood, but even the area surrounding the wood that is painful. And this is part of the healing process. For this type of pain, drugs such as ibuprofen or aspirin can be used. They are non-steroid anti-inflammatory drugs. They work by blocking an important class of mediators of inflammation called prostaglandins. In the full lecture, you will learn how prostaglandins are produced, and now we can block their production using drugs. Briefly, when cells are damaged, they produce arachidonic acid. Then there are two enzymes, COX-1 and COX-2, that convert arachidonic acid into prostaglandins. These are chemicals involved in raising the body temperature, causing tissue inflammation, and lowering the threshold of nociceptor. Using drugs such as aspirin or ibuprofen, we can block COX-1 and COX-2, reducing the production of prostaglandins and therefore reduce pain. But unfortunately, sometimes this alarm system goes wrong and pain becomes chronic and debilitating. So, for example, after an injury, when the pain lasts further the healing time, after a surgery or after a trauma, whether most of the patient will return to their normal life, some mothers will develop chronic pain and long-lasting disabilities. Inflammatory pain is one type of pain, and then there is another important type of chronic pain that is particularly problematic because it does not respond to the traditional pain therapies. This is called neuropathic pain and is associated with nerve damage, usually in the peripheral nerves of your arms or your legs, but it could also came about also from damage in the central nervous system, such as in multiple sclerosis, for example. Diabetic neuropathy is another example of neuropathic pain, and postherpetic neuralgia is another example, as you can see in this picture. This man who has been affected by a particular virus, an herpes virus, this virus got into the nervous system, and even the lightest touch on his shoulder will produce terrible pain, excruciating pain. By definition, chronic pain lasts longer than 3 months, usually outlast the original cause, but can also have no apparent cause. So why is important to study pain, and in particular chronic pain? Well, about 20% of adults suffer from pain globally, and 10% are newly diagnosed with chronic pain each year. In the UK only, 28 million of people suffer from chronic pain. And pain negatively affects your quality of life. As you can see in this graph, patients with chronic pain, they develop depression and anxiety. They have difficulty in sleeping. They have lack of energy. So the overall quality of life is affected. So how we can treat this patient? One of the major approach to pain relief are opioids. And as I said, opioids are heavily in the news these days. And opioids such as morphine are not a bad drug. So morphine is a good drug. At the moment, there is nothing better, certainly for patients with cancer pain, for example, or patients with severe pain. So in the field lecture, you will learn how morphine works, and we will describe the mechanism of action of morphine. So morphine binds to specific opioid receptor and induce a cascade of events that will reduce pain. We have all heard of the endorphin for sure. So these are molecules that are already in our brain. They are peptides, and they bind to the same receptor that morphine binds. And then endorphins, they can block pain. They are our endogenous painkiller. They are also responsible, for example, for the pleasure after exercising. So let's look a bit closer and very briefly at the mechanism of action of our endogenous painkillers. So for example, when we hurt our finger, the painful information travels via afferent fibers and reach the spinal cord, and then all the way up to the cortex, allowing us to give meaning to the pain, so where it is, how painful it is, and how we feel about it. This is what we call the ascending pathway. Our body can also decrease how much pain we feel by activating our body's natural pain-killing system, because we say that endorphins are already in the brain. This is the descending pathway. So normally neurons in the descending pathway are inactive, but these neurons can be activated in response to pain and release endogenous opioids in the endorphins in the brain. As a consequence of activation of this pathway, the ascending pathway is shut down and the pain signal is no longer able to reach the pain. And this is exactly the mechanism of action of morphine. And of course, in the full lecture, we will describe what happens at molecular level, and we will dissect out this pathway and describe it more in detail. You can inject morphine or you can take it orally, and it will bind to the same opioid receptor that are bound by endorphin. So activation of this receptor will switch off the pain response. And this is not just for morphine, but also codeine, fentanyl, and other opioid drugs. And as I say, these are the best drugs we have now for severe pain or for cancer pain, for example. But the problem with the use of these drugs is that they have a lot of side effects, such as nausea or constipation, and addiction and tolerance. And the problem of this side effect is because these opioid receptors are not just in the nociceptive pathway. These receptors are all over the place in the nervous system. So for example, a person who is an addict on heroin is not taking heroin in order to get pain relief, right? This person is taking heroin because it's trying to get an high. And they get high because the morphine and heroin, they bind to the opioid receptor in the limbic system, that is the area of the brain involved in our emotional response. And we mentioned the fact that in the USA, over 2 million of people have opioid use disorders, which most starting with prescribed opioid painkiller. And it is estimated that every 11 minutes in the USA, somebody dies due to opioid. And data collected in 2017 show that GPs in England wrote 23.8 million prescriptions for opioids, the majority of which will have provided little to no benefit for patients. It is also estimated that for every 10 patients who are given opioids for chronic pain, probably only one will have a benefit from treatment. All the other 9 patients are taking a medication which is ineffective and may also cause a lot of unwanted side effects, including nausea, constipation, or breathing difficulties. So it should be clear to you why do we need more painkiller in order to have drugs that are safer to use and they are more effective compared to the drugs available at the moment. And our aims as pharmacologists is to develop drugs that can act on specific target in the nociceptive pathway and improve the quality of life of patients with chronic pain, reducing their pain, also not inducing severe side effect. With this, I will end my tester lecture, and in the real lecture, I will obviously explain pain, the nociceptive pathway, the mechanism of action of pain treatment in more details, and also we will describe new drugs which are currently tested to treat chronic pain. Thank you very much for your attention.